Hey there. Good afternoon. Guess what time it is? Well, it's 2 minutes late. It's 2 minutes after the top of the hour, and I'm Dr. Randy Fink. Welcome to Fertility, Halloween Fertility with Fink and Friends. I am the clinical director of IVF services here at CNY Fertility in Colorado Springs, also the medical director of the Miami Center of Excellence in sunny South Florida. And I am the ringmaster today. Happy Halloween to everyone. I hope you all wore costumes. And if you didn't, shame on you, because you know what? It's fun to be a kid sometimes. It's just a great feeling. We had some folks come in today who were wearing costumes for their, some people wore this lovely little gown and a surgical hat for their retrievals. Isn't that crazy? And but we had some people dress up very nicely for their embryo transfers. And what a wonderful spirit that is. So happy Halloween to everybody. Great to see you all. Let's see who's joining. We've got a couple of different Facebook, or rather a couple of different Instagram feeds here. We've got Facebook and YouTube and LinkedIn right over here in the middle. So who do we have? Who do we have? Our first joining today, NYC IVF. Hello. Thanks for being here. You are number one on the CNY side. Oh, there's Lola Garcia. We've got Honor and Justice, Kathy Hull, Ricky Marcus. Hello. Good to see you. L. Higgins. We've got Tamara Suarez. We've got Emmy and M. Murphy and Southern SoCo, and I can't even pronounce your name there. Harhat, I believe is the way I say it. B. Voyager, and oh gosh, so many other folks. Nanushet, thanks for joining. And over on my side, I see my beautiful mother and father in sunny Southern Alabama, in LA, as we call it, Lower Alabama. Happy Halloween. M. Salustio, nice to see you, Alexis. And we've got Pretty Binky, happy Halloween. Hello to the Tongue family, Brock and wife, Courtney Gabbard, Mrs. Vence, of course, from the beautiful state of Kentucky, Kylie Ann Diaz. Let's see, who was our first here? Oh, we also have Shay, the lovely and talented medical assistant from Colorado Springs. Shay has joined us here. And Pretty Binky, you are number one on today's Fertility with Fink and Friends. How is the day, everybody? We got our first snowstorm here in Colorado Springs. And that happened on Sunday. It was got about up at my house, maybe about 1.5 feet of snow. And I live kind of up on a mountain, but yeah, it was great. And fortunately, there was no school, so nobody had to miss any school that day. Too much to the dismay of the kids. You guys wearing costumes? Because if you are, I want to know about it. I wish I could see them, but you can tell me if you do. Speaking of spooky things, I hope you all had a chance to see my post on my Instagram, which if you don't follow, kindly do so. And that is at Randy Fink MD. And we did a scary post about the story, the legend of the haunted ovaries. And I told that story. It's kind of a ghost story about a hidden book found in Dr. Kiltz's attic, and how it told the tale of a woman whose ovaries were haunting the hallways. And if you haven't seen it, take a look there, because when I talk in that voice, it just makes me feel all Randy. Randy's the name. So let's see. We got some questions starting to pour in here. And let's see what we can do. I hope you're going trick-or-treating tonight. Let's see. Chronically Ill Mama is saying, I have an HSN HSN done in 2 days. What should I expect? I'm not sure what you mean by an HSN. A hysteroscopy is we call that an HSC, or an HSG. The hysterosalpingogram is the dye test where we go to check if the shape of the uterus and that the fallopian tubes are open. So I'm not sure what you mean there, chronically ill mama, but I will answer that as though you're asking about the HSG. I have to tell you, the HSG is my is the least popular test really in all of fertility because it's crampy. It doesn't feel good. It takes about 15 seconds to do. We place a little straw inside the cervix and place a teaspoon of fluid inside the uterine cavity while taking some x-rays. And in so doing, we can see that that dye, that fluid spills out through the fallopian tubes and shows us that your fallopian tubes are normal, that they are open. We can also see the shape of the uterus. Most of the time after we do that HSG, we'll place a vaginal ultrasound probe inside, which will then really, we put some fluid inside. So it separates the top from the bottom layers of the uterus and shows us what's going on actually inside the uterine cavity. So we get an awful lot of information about that. When I do this test, I will say it's certainly not the most pleasant thing, and I don't love having to do it to people. But when I do it, it's over with pretty quickly. It's not, hours and hours of torture or even minutes and minutes of torture. It takes about 15 seconds to do. So if that's what you're asking about, ill mama, I hope it answers your question. Cat B 825, how much time should I wait after a laparoscopy to remove stage 4 endometriosis before I can do a retrieval? So usually, there's no great evidence to point us one way or the other in that situation. So normally I would say, usually you're going to do that laparoscopy in the first half of your cycle, because that way we're sure that you're not accidentally pregnant when we're doing that procedure. If it's stage 4 endometriosis and it's a pretty extensive excision, I would probably give that at least a month to heal and let the levels of inflammation go down before I think about doing a retrieval. So let's say you maybe 2 to 3 weeks later you get your period. I would sit that cycle out, and then the next cycle I think you're fine to move in to your egg retrieval. Hi to Sarah K. Voss and BJ Pumping. Nice to see you this fine afternoon. Let's see. HSG, she's saying HSG saline instead of dye. So there is a procedure that we can do with basically with bubbly water. So instead of using the dye and the X-ray, we can use bubbly water and an ultrasound. And if you know how to do that, then we can see that the tubes are open that way. That test typically takes a little bit longer than a straightforward HSG, but is also a pretty straightforward thing to do and occurs in a very similar fashion. Mine Girl Health 11 says stomach ache and cramping post 7 days after ovulation every cycle with no pregnancy outcome. The cycle is normal and the pain is minimal. Is there any concern with having pain post ovulation? Well, it always, makes me wonder when folks have pain, where's that pain coming from? The most common thing that causes pain, especially a week or so after ovulation, is that you develop what's called a hemorrhagic corpus luteum. And what's happening in that scenario is that your ovary is releasing an egg. And when the egg leaves the ovary, it's like a car leaving a garage. It leaves behind an empty space, and your body hates empty spaces, and so it tries to fill that space with some fluid. And that fluid, sometimes that fluid is actually blood, and that's what a hemorrhagic cyst is, or a hemorrhagic corpus luteum. The corpus luteum is the space that happens after you ovulate, and it's those cells in that corpus luteum that results in your making of progesterone. That's where your progesterone hormone comes from. So, but if you've filled that space with blood, it's literally a bruise on the ovary, and it doesn't feel good. So, my suspicion is that you're having a hemorrhagic corpus luteum every month. Would be my guess. It's very easy to see that by ultrasound. So, if you haven't had that imaged before, I think it's a reasonable thing to do. To do an ultrasound around that time, a week or so after ovulation, so that you can know kind of what's going on in your ovaries there. Well, let's see. Carly on the Facebook side says, had my FET today. Congratulations. That is awesome. Well, we have nurtured Shanna here, who has a wonderful Instagram page, by the way. I had a natural FET cycle that was canceled due to early ovulation and another natural FET that had to switch to a medicated cycle. Is that typical? Hoping to do a natural with this one. Well, so what's happening there, in a natural cycle, we want you to ovulate. We want you to make your own eggs, because that's how you make your estrogen. That's how you make your progesterone, so that we don't have to give you all that stuff as a artificial medication, that it's coming from within your own body. And when we do that, it oftentimes results in really kind of some better outcomes, we believe. So, but you have to have enough estrogen time to be able to build up the lining of the uterus. And so if you ovulate early, that means that you may not have enough estrogen time. And so your lining just doesn't have the chance to get thick enough. So that sounds like that's what happened there. And then if something went wrong, it wasn't progressing the way we wanted it to, then in a different situation, you may have then had that converted to a medicated cycle. It's not an uncommon thing. So one potential solution to that, Shanna, is to do a modified natural cycle. A modified natural is where we give you some letrozole. We give you some ovulation induction to make sure that your ovaries will produce an egg in the normal, predictable fashion. So if in the fully natural version, your body is trying to do its own thing and trying to break all the rules, we can just try to hold it in line a little bit better. And there's actually some evidence that shows us when we use the letrozole, it may improve the outcomes of that natural cycle. So I would think about doing what's called a modified natural cycle. And that's what that is. Pretty Binky is asking about, my partner and I are planning to travel here to Colorado Springs for an egg retrieval and fresh transfer in January. Is it okay to travel around that time frame? Is the weather bad? The weather is rarely bad here. We had a little snowstorm. It was a Saturday night into Sunday morning, and I said, I live up on the mountain, and we got a fair amount of snow. But by 10 o'clock in the morning on Saturday, the roads were already clear, and by that afternoon, there was kind of barely anything left any place on the roads, and so they're pretty good about that. The only thing has to do with, if you're going to get a big snowstorm, then that can certainly delay flights, and even on a good day, flights are plus minus in terms of reliability, but it's generally not a big deal to believe it or not, it's not a big deal to come to Colorado in the wintertime for a procedure. In fact, I hesitate to say it, but I think it may even be a bigger deal to go to upstate New York to one of our facilities there for a procedure. Buffalo, there was that one weekend, Buffalo got, I think, 8 feet of snow, and all that entire area was shut down due to the ridiculous winter storms. We don't get weather like that in Colorado, or at least in this part of Colorado. Certainly in the ski resorts and that sort of thing they do. But the joke over here is kind of that, okay, it can be snowing in the morning and you can be playing beach volleyball in the afternoon. It's not unusual that it snows in the morning and then it's 60 by the afternoon. So I would not consider that a significant threat. So pretty Binky, we are excited to see you here in Colorado. Hello to Real Rose. Let's see what else we have here. Angela Polk joined us, and we've got Nat McCreary. Over on the Facebook side here, Tamara says, I just had a baseline for A medicated donor egg FET. I have a TSH, which is 2.47. Okay, so let's just back up there so everybody knows what we're talking about here. A medicated frozen embryo transfer cycle using an embryo that was derived from a donor egg. Okay, fabulous. The thyroid hormone level is 2.47, which is close to the 2.5 level that we use for fertility. Is there any concern regarding implantation that it could be affected by this TSH, and should I be taking medication to bring the level down? It's a good question. So the thyroid hormone. So basically, what you're telling me there is that your thyroid is normal, but it's close to being around that cutoff that we use as optimum for fertility. So the thyroid gland lives here in the neck, and it controls your body's metabolism. The higher the number of the TSH, the thyroid stimulating hormone, the higher that number, the lower your function of your thyroid is. So let's say that your TSH came back with the level was 6. I would say, ooh, you are overtly hypothyroid. Your thyroid level is too low, even though that number is high. Conversely, the lower that number is of the TSH means the higher the function of the thyroid. Well, so for optimization of fertility, we want your TSH to be between a 0.5 and a 2.5. And so, Tamara, you're suggesting that at 2.47, you're worried because it's close to that 2.5. Well, the cutoff exists for a reason. And the reason is above 2.5, people don't do as well. Below 2.5, people do better. You're at a 2.47. I have not seen any data that says people do better at a 1.5 than a 2.4. So I do not think that you need to treat that. If that result came across my desk, I would not recommend treatment for you. Now, if you wanted to treat that, to take a little low dose of thyroid medication, I don't think it would harm anything, but I wouldn't necessarily recommend it because you are already in the optimum range. And what's going to happen is that we're going to kind of keep testing that thyroid hormone. So you'll have your, you did your baselines today, so we tested it there. When it comes time for once you do your beta, we're going to test it again there. So we're going to kind of keep on top of that. And if it fluctuates, if it changes, it's very easy to treat. So hopefully that's helpful, and best of luck in this cycle, my friend. Let's see. We've got Leanne here with us. Leanne on Facebook is saying, I have spotting like clockwork 7 days after ovulation. Last ultrasound showed that I did ovulate, but the spotting still happened. Does this mean I have a corpus luteum issue? The progesterone labs always come back high in spite of this. What do you think is the cause? You know, it's another really great question. So my guess is that your progesterone level, so I will say there are some people who have something that's called a luteal phase defect. And that is a problem in that second half of the cycle after the ovary has released the egg. That time period typically lasts 2 weeks from the time of ovulation until the time that you get your period. If it's not 14 days, it may be indicative of a luteal phase defect. So what does that mean if you start spotting? Well, it probably means that there is some fluctuation of that progesterone level. And now, is that enough of a fluctuation to cause you to have a pregnancy issue? Well, you know, if you were in my general gynecology practice and you told me, hey, I'm trying to get pregnant, but this is what's happening every month after I ovulate, then I would say, I think it's very easy to just add a little vaginal progesterone. It won't affect your progesterone level, but it'll affect the lining of the uterus. So you place the little progesterone pill in the vagina, It affects the lining of the uterus and will really help to potentially resolve any issue that's there. Does it mean that you have some issue? No, not necessarily, but certainly in somebody who's trying to get pregnant, it would make me want to scratch my head. Wait, there we go. It made me want to scratch my hat to know kind of what's going on with your corpus luteum. So really good question. Amy is asking a question also on the Facebook side. Is it better to do all the supplements to help with egg quality for 30 days or is 90 days better? Our egg quality is okay, but we want the best chances for the egg quality to go up. Well, the data tells us that there's probably a 2 to 3 month window during which time we can affect the egg quality in the ovaries. And so when we send you a list of what we think you ought to be on for egg quality, and my list comes, directly from the book, It Starts with the Egg, which I have over there. It seems like every other episode here, I'm always grabbing that book and waving it around. That is the evidence-based protocols on what supplements will help with egg quality. And basically what it says is that 2 to 3 months is probably the best window. So 1 month, I think, is okay because 1 month is better than nothing. But certainly if you can do it for 2 to 3 months, Amy, I think you're probably doing yourself a favor. Now, that said, we have to balance that against, well, what's happening in the ovaries? Because each month that goes by, we have the potential to lose about 10,000 eggs, which is crazy when you think about it. So that's the kind of the balancing act, we want to get the eggs out as quickly as possible, but we also want to be able to optimize what we're getting while we do it. Well, it's about 25 minutes after the hour. Thanks for being here on this Tuesday afternoon, as always. Last week, I was not here. My good friend, colleague, Dr. Kiltz, sat in for me. So my regards, my hat goes off to Dr. Kiltz for taking care of that. We're certainly appreciated. We've got a couple of different Instagram feeds. We've got LinkedIn and Facebook and YouTube over here in the middle. So if you have questions about your fertility or women's health, this is the place to ask them, my friends. Let's go back over to this Instagram side. Comes from Beauty by Coda, born and raised from Colorado, moved to Buffalo with my wife, and I got confirmation of pregnancy in the Buffalo clinic. It was a beautiful experience being accepted as two married women. Well, absolutely. And that is something that we take great pride in every single day, is helping couples from any background, no matter what their gender or no matter what their choices are, helping these folks to make families and being able to do it in an affordable way. It just reminds me, I had a consultation with a patient the other day, and we were talking a little bit about about the cost structure at CNY. And I typically don't, it's out of I don't have anything to do with it, not part of my wheelhouse. So there's a document that we put in your portal that's called the Financial Welcome Packet, and it kind of goes over all the costs. But this is the only company I've ever seen that puts all those costs up front, actually even on the website, that there's no hidden fees, that there's no, really try to make this accessible to everyone. But she was telling me that she had just come from a place where she was doing her IUIs locally, and they charged $35,000 for a cycle of IVF, the very same cycle of IVF that we charge $3,995 for, just under $4,000. So $35,000 is just it's astonishing to me, just astonishing. Equestrian 33, I was told if my retrieval fell on a Saturday, I wouldn't be able to have my polyps taken care of at that time in Colorado. Is this true for all CNY locations? And that's not necessarily true in Colorado either. So I will do a polypectomy at the time of an embryo, rather at the time of an egg retrieval. We'll do a hysteroscopy. So that's a camera that goes inside the uterus to be able to take a look around. If we see a polyp, we can remove that polyp. Now, our nurse practitioner here, Brandis, does diagnostic hysteroscopies, but as the surgeon in the facility, I'm the one who does the operative procedures, and I don't work every Saturday. So that is the caveat there. Syracuse can do it every day that they're open. Albany does not do it at all. I am not sure about Buffalo, and now that Sarasota has come online, I believe Dr. Condrup in Sarasota will do a hysteroscopy at the time of retrieval as well. So hopefully that answers the question there. Cheyenne Chippewa. Ooh, I like that name. Lucky me again. This is all good stuff here. Glad to have you guys on this Tuesday afternoon. L. Higgins says, I had 2 failed transfers with PGTA tested embryo, the next cycle going for a modified natural. And I think that that is a great plan. With a PGT tested embryo, we know that you should have about a 60% probability of being able to get pregnant. So we expect about 2 embryos, 2 tested normal embryos. It'll take for you to get a baby if you have those tested embryos. If 2 of them have rolled around, you haven't gotten pregnant, really makes us want to scratch our heads or scratch our hats and say, what's going on with that? So I would always want to look at, well, is your cavity evaluation up to date? Have you evaluated the uterine cavity? And that would be a hysteroscopy or a saline sonogram. And this is something that we want to have done at least once a year. And then I'd start really wondering about endometriosis, because that's another thing that can definitely stand in the way of an embryo being able to implant. Let's see who else is talking to me over here. Dancer says, after doing my second ovarian PRP back to back, when should I start IVF? After my period or after 1 month from my last period? Just a little bit confused. No problem. That's confusing. You know, ovarian PRP is really a very promising thing. It is considered to be experimental. So there's not a lot of data necessarily to guide us on that. But PRP is when we take a tube of your blood and separate out your body's healing components. That is the part of your blood, your growth factors, your tissue factors, the things that do good for you in your body. If we can then place some of that material back into your ovaries, then we may be able to do things like improve egg quality, or really just, develop new blood supply to the ovaries and juice them up, make them a better place, and improve some outcomes in IVF. That's the thinking anyway. So we don't know that for sure, but it certainly empirically seems to be the case. When I do PRP for folks, typically I do see that it makes a difference. Now, some people will do 1 PRP, and then a month later, they will do their first retrieval and then do a PRP again in anticipation of doing another retrieval after that. And then a month later, the next retrieval. I think that after doing the second PRP, if you're going to take a break, by the time you get your next period, I think that's probably a good time to start, because start with your stimulation, because the effect of the PRP, is limited. It's not going to last forever. The thinking is that it's probably on the order of 2 to 3 months that it has an effect there. So that's kind of what my thoughts are. Dr. J, 2013, planning on starting another cycle in January. The last time I primed my cycle was early. Last time I primed my cycle was early. It was about 20 days. Should I prime for more than 1 month? Really, well, it depends on what you're using for priming. So priming is when we use medication before starting IVF in order to try to improve the outcomes of that IVF retrieval. We can use estrogen and progesterone. There's a large supplement list that comes from the book we talked about before. And sometimes we use low-dose naltrexone. Sometimes we use omnitrope or metformin to prime the ovaries. And those are all good things. How long does it take? I'd say at least a month. But if you do it for more than 1 month, then that's certainly probably a benefit as well. I would say at the very least, it's 1 month. If you're doing priming, plan to do it for a month. But beyond that, anything else you can get is icing on your cake. So at some point, you just got to feel good about eating your cake and going for it. Hey to Facing Destiny, nice to see you there as well. Candace is here in an FET, doing an FET cycle right now. I had a receptiva score of 1.5, told to basically ignore the low positive and do an immune level 3 and a modified natural. Anything else I can do before an FET? So the supplements that we recommend for the evidence-based supplements for embryo transfer, your prenatal, vitamin D, vitamin E, L-arginine, CoQ10, and some fish oil. So I would definitely add those things to your life if you're not doing them already, because I think that they will help. Siciliana Melissa, does an HCG booster increase your HCG level over the 2-week wait, or does it keep the same level of HCG in the system? What would this look like on a home pregnancy test after an FET? Okay, so this is a really great question. So the HCG booster, HCG is of course the pregnancy hormone, and in a natural cycle, the HCG booster is said to really make a difference. Why is that? Because it's metabolized in the body as some more progesterone. And so you're making your own progesterone there. It just allows you to make more progesterone, and that is a good thing. In a medicated cycle, the HCG booster has not really been shown to make a difference. And so I'm not so enthusiastic about it in that scenario. But from in a natural cycle, HCG booster is a good thing. You give yourself a little shot, 250 units daily, typically from the time of embryo transfer. All right, but what's the downside of doing that? The downside is that when you do your pregnancy test, it's going to be positive because we're giving you HCG. And if we're giving you HCG and we're testing the HCG, guess what? Positive. So what's that number going to look like? Usually it's in the up to the mid 20s. Sometimes it's a little lower than that. And it also depends on the time of day you test it. So if you're doing your HCG booster at every day at 11 o'clock in the morning, but you do your pregnancy test at 10 o'clock, obviously that number is going to be lower because that's what's called at a trough. It's down at the bottom of the level before you give yourself another injection of it, and then that level goes up to its peak. So that's the difference between a peak and a trough. Normally, that's going to be approximately, as I said, in the kind of mid 20s. So what I tell folks is that if you're doing that kind of cycle and you're doing the HCG booster, it's going to take the second pregnancy test to show you that you're really pregnant. Because if it's a real pregnancy, you're measuring the HCG level that's coming from not only what you're giving yourself, but from what your body is making. So the level is going to be going up. If in a urine pregnancy test, your line is getting darker, that means that your level is probably going up. So guess what, Melissa? I think that means you're pregnant. God willing. Fingers crossed. Good luck with that one, my friend. Is it better to do this comes from Melissa. Is it a different Melissa, is it better to do PRP and an HCG wash separately or together? You can do them together because then it's just kind of easier to sort of do it all in one sitting and not have to come back a second time. So yep, it's okay to do those together. Let's see, going back over to the Facebook side. Hey to Sally from Trinidad. Glad to have you here. Um, okay, we've got Emily Mortensen here as well. Thoughts about transferring a 4AA and a 5cc at the same time. So I don't recommend that we look too much at embryo grading because the grades really don't correlate with the outcomes. As you probably know, there is a there's a set of guidelines that we follow that comes from the American Society for Reproductive Medicine, the ASRM, and these guidelines tell us what we are supposed to be doing with embryos and whether it's one or whether it's two and whether it's a day 3 embryo or whether it is a blast. And so each of these things kind of makes a difference. And so I would follow the guidelines, Emily. And so some of it depends on how old you are. It depends on it depends on how many transfers you've done before, and it depends on the embryos themselves. But the grade should really not make too much of a difference to you. Again, the whole idea of embryo grading was that it was sort of designed to see if there was a way. I'm trying to get myself out of the sunshine here. You see that? Look at that. If there was a way that you could look at embryos under the microscope and determine from a series of observations about the structures in those embryos, whether they were normal. Well, it turns out the answer to that is no, you can't, because you can have a very highly graded embryo that is chromosomally abnormal. You can have a very low graded embryo that is the chromosomally normal one. And that's really ultimately the question that we're after, which of the embryos are normal. So that's why if you have a tested embryo, if you have tested your embryos, done PGT, and you know that that embryo is normal, the grade really doesn't matter anymore. Because the most important feature is what does the genetics show. Let's see here. Lisa is with us on Facebook. Happy Halloween to you, my friend. I have an X-linked genetic disorder. I plan on doing PGT-M, but not sure if I'm doing should do PGT-A as well. Okay, so just to explain the difference, PGT-A is pre-implantation genetic testing for aneuploidy, which means it's looking to see are your chromosomes normal, as opposed to PGT-M. And PGT-M is, let me get that out of the way. There we go. PGT-M is where you're looking for a particular mutation. So the M stands for mutation. Should you do them both? Well, in fact, they do them both. So if you're going to do that iPad just dropped. Let me see if I can fix it. If you're going to do PGT-M, then they will do PGT-A automatically generally with no increase or no difference in price. So they really kind of come together, and hopefully that helps to solve that problem for you, because that one's pretty easy. Jenny is asking, how many type 1 diabetics come to CNY? We see type 1 diabetics, certainly every week. Are they successful? I'd say they're no less successful than anyone else with diabetes. The biggest issue is really how tight your blood sugar control is. We want you to be as tightly controlled as possible, as best controlled as possible at the time of egg retrieval, because the higher your hemoglobin A1C is, which is the long-term measurement of your blood sugar, the higher that number is, the greater the probability of birth defects, because there is a higher chance of birth defects in folks with diabetes for that reason. But assuming that your A1C is basically in the normal-ish kind of range or below about a 7.5, which is still diabetes, but 6.5 is kind of the cutoff there, your risk for birth defect would be the same. And so then we want you to be as tightly controlled as possible when it comes time for embryo transfer, because we want that lining to be as hospitable as possible to your embryo. So folks with diabetes can do just as well as anybody else, but like the rest of life, we want your we want your blood sugar to be well controlled. Let's see what else we got going on here. Lots of folks have joined there on the CNY side, just making sure I still have audio over here. Sally is asking, priming from the 9th to the 26th of October with Omnitrope, with esterase and prometrium. Started stims the 27th of October. Didn't see my cycle either. Went in for the first ultrasound yesterday and saw a 6-centimeter ovarian cyst in my right ovary. 6 centimeters. And then 1 follicle in the left ovary. The nurse advised to continue the stim today and tomorrow and see how the ultrasound goes. I'm not sure that makes sense to me. If you, Sally, you're in Trinidad, so I know things are a little bit more difficult as it comes to, when it comes to doing your monitoring and such. But with a 6-centimeter cyst in the ovary, that's pretty big. 6 centimeters is pretty big. When things get above 5 centimeters, we start worrying about them potentially twisting on themselves, and that's called a torsion. A twisted ovary is a surgical emergency, and a big cyst like that may take up some really valuable real estate that makes being able to retrieve other eggs from that side difficult. The other concern is, let's say that we go through this and then we get you pregnant and you've got that 6-centimeter cyst in the ovary. Well, what happens then if you're pregnant and then you get a torsion and you end up having to have an emergency surgery during the pregnancy? That's generally a bad idea. Sally, I hate to say it, but I'd like to see a 6-centimeter cyst not be there when you start your stim. It should not be. If that had happened in one of our offices, we would have canceled it really from the get-go. So not the news I'm sure that you were hoping for, my friend. Let's see. Haley is here. Hi, Haley. Haley Kavanaugh. It's almost 22 weeks. Oh, gosh, you're 22 weeks with a baby girl. Thanks. Thank you. Thanks to your office, she says. I can't thank you enough. That makes me so happy, Haley. That is awesome. 22 weeks. So you are more than halfway there. You are on the downhill side, even you're getting on the bigger tummy side, right? So that's a really wonderful thing. Okay, let's see what else we got going on here. Hi to Linda Grossman. Hi to Chelsea. Hi to Brooke. Hi to Lizzie. Okay, Kat is asking, what causes follicles to grow twice as fast as they should? I had a baseline on Monday, and by Friday I had 5 ready to go, but only 1 ended up being mature. 1 was immature and 3 degenerated. So some of that really has to do, some of it has to do with genetics. And what we call that is the synchronized way the follicles grow. And so we like for follicles to really kind of all grow together if they can. And sometimes there are some things that we can do to try to help. See what you did to me? That was your fault. Sometimes there are some things that we can do to try to get folks' ovaries to grow in a more synchronized fashion, because that sounds like it was a dissynchronous growth. You grew a couple of them really fast and a couple of them really slow, and so ideally they would all really grow at the same rate. So there are some different things that we can do about that, and that's probably worth talking about the next time. But glad you got some response there. But yeah, that is frustrating. Do we ever transfer more than 1 PGTA tested embryos? 38 years old, to be closer to 39 at the time of transfer, recurrent pregnancy, loss, and secondary infertility. Well, so the ASRM guidelines tell us that we really only want to transfer 1 euploid embryo. Why is that? And the answer is because with even a single euploid embryo, your odds for getting pregnant are really very, very high. We don't want you to have more than 1 baby. There are a lot of people who say, well, I don't mind twins, or I really want twins. We don't want you to have twins. The fertility industry does not want you to have twins, because in most cases, putting back more than 1 embryo does increase the probability of having a positive pregnancy test, but it does not increase the odds of having a live birth. So what does that mean? It increases the risks to both mom and baby and increases the risk for pregnancy loss. And that's something that we certainly don't want. So I will always recommend a single euploid embryo. There are many practices in the United States that will not even discuss it with you, that say it is unethical to even discuss the possibility of doing more than one euploid. The answer is no. At CNY, we will do it. We will do it if you demand it, but it is against medical advice, generally speaking. And sometimes when that happens, if insurance is covering it, then they will refuse to cover it. So, honestly, in most cases, it's a bad idea. So I hope you'll take that at face value. Let's see, Heather. Hi, Heather Lavetta. I realized today that I've been taking one instead of two letrozole. Today is day 5 of meds for a modified natural FET. How bad did I mess up? Nah, probably not a big deal. So most of the time, the whole goal of the modified natural FET is to make sure that you're going to release an egg. 2.5 milligrams in most cases is enough to make most people release an egg. So usually we'll do 5 milligrams just because it's, sort of doubly sure, but 2.5 will be okay. If you're taking this day 3 through day 7 and you're on day 5, go ahead and start taking 2 of them today. I think that won't harm anything and also may just help. But nope, not a deal breaker, Heather. Don't worry. I think you're going to be okay. Thanks for asking that question. That is a good one. Let's see what else we have here. This comes from Brittany over on Facebook. I transferred on October the 26th. I started feeling shaky several days after. Had a pink and brown spotting day of and day after transfer. What would cause the shakiness? That's a good question. There's nothing specifically. So if the the transfer was on the 26th. You're probably, right around implantation time. Sometimes people will get a little crampy around the time of implantation due to a chemical in the body called prostaglandin. But shakiness, I'm not sure there's anything physiologic I can necessarily point to right off the bat that is directly related to having the transfer then. But as long as you're feeling better, I'd say that's a good thing. The spotting is very, very common. So certainly after an embryo transfer, we're messing with the cervix and we just put a little catheter up into the inside of the uterine cavity. So it's not unusual that you shed off a little tissue. And sometimes you'll even see a little bleeding when the embryo implants, and that's called an implantation bleed. The other thing I will tell you that 50% of normal pregnancies will have some cramping and bleeding in the first trimester. So even after you've seen the heartbeat, once we look and we see a heartbeat, we know that 95% of those pregnancies will continue growing without having a problem. Now, sadly, 5% of those can still miscarry, but odds are way better. By the time you see the heartbeat, odds are way better than your odds in Vegas that everything is going to continue. So best of luck to you there, my friend. Let's see. It looks like Elk or Elky. I can't quite see it from here. My glasses are a little dirty, so sorry about that. And I guess means I'm getting older. Good evening to you. I'm gearing up for an FET, and I have 4 frozen day 3 embryos. Would you recommend transferring one at a time or multiples at 44? Do they affect each other once they're in? As in, if I have a bad one and a good one, can the bad one sort of drag the good one down? The answer is probably not. So the thinking is that it's not that a bad one is going to affect the good one. So at 44, the recommendation, the reality is that at 44, the odds of having 4 normal embryos, chromosomally normal embryos at 44, the odds of that are very low. The possibility of having one of those embryos be normal, you've got a possibility of that. But the likelihood that 4 of them are normal, not so much. And so the guidelines tell us that, you can put all 4 of those embryos in at once. What might be the advantage there? Well, in that situation, what you're doing is that you're certainly increasing the probability of a positive pregnancy test without increasing the probability of pregnancy loss, because we have reason to believe that all four of those embryos will not implant. In fact, even the likelihood of two of those embryos implanting is low, because they're also day 3 embryos. And so the guidelines say if you'd like to put multiple in at one time, it makes sense, because that means it's going to be fewer FETs that you're going to have to do, because you have to pay something for the FET every time you do it. So if you can do that all in one shot, you're not decreasing your odds at all. Now, that same thing is not true at a different age group, but at 44 with a day 3 embryo, that's the fact. And so that's probably, I think, what I would do. And if you were my sister, that's what I would recommend. Let's see. Haley says it's hunting season. Men have priorities. I wouldn't know. Jenny there says my husband got a deer and had to, of course, call and tell me, and I missed it. And what did you say? Oh yeah, I think because you asked again about the diabetics, and I said yes, every day. Yep, all the time. And Jenny said she missed it because her husband told her about the deer. Well, yep, men have their priorities. There you go. You know, he should be watching Fertility with Fink and Friends. Fertility with Halloween, Fertility with Fink and Friends, and deer. Because I'm wearing the costume here, okay? And if I could do it, well, I guess he's wearing the hunting costume, so that really must count for something, I suppose so. What else we got going on here? We've got about, looks like maybe 7 more minutes or so. I see my friends, lots of friends joining in here. Good to see everybody. And hi to Zenaida in Miami. She says, great costume. And my answer to that is, what costume? Oh, well, you know what? I already gave it away. I already said something about that. Okay. Over on the CNY side, Rashmi says we'll be traveling patients soon. Well, we are excited to have you into our world, my friend. Diana Marie says, I can't wait to start treatment with you guys. Consultation is in 2 weeks. So much hope, and we have hope for you too, because gosh, this is, I tell you what, I got to tell you, I think I have the greatest job in the world, being able to help people to get to their dreams. And Diana, we can't wait to see you pregnant. BJ Pumping says, can I do ovarian PRP while priming? Priming with Novarel. I did ovarian PRP last month. Would like to do another. The answer is absolutely yes. Yes, you certainly can, my friend. Hopefully we'll get to see you back for that. What else we got going on here? Oh, Third Grade Duck. That is a good name. That is a good handle. I like Third Grade Duck. Long wait for my appointment, says Rashmi. January. That is a thing. It takes a little while to get in. Once you get in, once you have that appointment, typically then things start to move pretty quickly. Now, CNY has just engaged the services of an organization that is designed to help expedite getting your testing done ahead of time, and to make sure that everything is all lined up so that by the time you have your consult, there is very little delay in getting you to be able to start your treatment. But even still, worst case scenario, it's typically not more than a month or so once you're over the fence. It's just getting that first consult, and that's because there's a limited number of people, and at this price point, we really do everything we can to try to get everyone to be able to participate. Honey Girl, hello, Honey Girl 931, and it's the 931 that makes all the difference, right? If taking DHEA can lower FSH, can stopping it cause it to rebound and go higher. Mine went from 8 to almost 17, and I'm having trouble explaining it other than stress. Well, so the first question is, when did you draw the FSH? Because the FSH is quite variable during the time of your cycle. FSH stands for follicle stimulating hormone. And depending on how much estrogen your body is making, that has the direct control. If your estrogen level is low, then your FSH is going to be high. If your estrogen level is high, then that will lower your FSH. So yes, DHEA can have an effect on the FSH, and is generally speaking said to be a good thing to do for priming, especially in folks with a diminished ovarian reserve. So that's one of the supplements that I usually recommend, and it's 25 milligrams 3 times daily, DHEA, if your AMH level is less than 1. So yes, I think that probably does make a difference there in the FSH, but also, again, depending on what time of the month or what time of your cycle you had the test drawn. I am so, oh, forgive me for saying it wrong. I can't get there. How much metformin do you typically recommend? So I use the extended release metformin. Metformin is a medication that we use in folks with diabetes. It helps to lower blood sugar. We use it in folks with polycystic ovarian syndrome because it helps them to ovulate with greater frequency. And in the IVF world specifically, it helps with egg quality. So depending on your body weight, so I will usually use either 1,000 milligrams or 2 500 milligram extended release tablets, or if you are above about, I'm going to call it 170 pounds or so, then I will usually use 1,500 milligrams, which would be 2 750 milligram extended release tablets. There's no hard and fast rule about that, but that's just kind of where kind of the way that I've always have always done it. Let's see. It looks like AMA, does thyroid affect implantation? Yes, indeed it does. Like we talked about a little earlier, we want that thyroid level, the TSH, to be between a 0.5 and a 2.5, both for egg quality and for implantation. So yes, it does. And that's why at the beginning of every FET or embryo transfer cycle at all, we will always test your thyroid. And that's the reason why. Danielle is asking, can I request my donor eggs be pushed to day 5 without doing PGT? So if you have purchased donor eggs, then you're talking about making embryos with those donor eggs. You can always grow embryos to blast without doing PGT. Yes. Now, if you want to do PGT, you have to have a blastocyst, which means typically day 5, sometimes day 6, sometimes day 7. But if you want to have a blastocyst without doing PGT, 100%, you can definitely do that. What else we got going on here? It looks like Nanuchet is a DHEA essential for transfer or for egg retrieval. It is it's an important supplement for egg retrieval. It really doesn't have a specific role in embryo transfer. There are some specific supplements for embryo transfer, and Rashmi is asking for an AMH of less than 1. What are the supplements on which I should start? And I would say, if you would please instant message me through Instagram at Randy Fink MD, I am happy to send you that list. Well, guess what, folks? Like somebody's saying, Doctor, you didn't answer my question. Mayfair, I missed it, but I don't see where it is. So instant message me there as well, if you would, and I promise I will answer your question, my friend Mayfair 72022. I didn't see the question. My apologies. It's straight up top of the hour, which means it is time for Fink and Friends to go trick or treating. I hope you all have the most wonderful of evenings. Thanks so much for being here as always. I am fond of saying infertility is not your book. You know what? It is not your novel. It is merely a chapter in your life, and it is one that we are here to help you rewrite. So in the meanwhile, choose kindness, choose love, and choose to be a part of this wonderful community. Thanks again. Happy Halloween. We'll see you next week.